This is the pituitary gland. This portion is the anterior pituitary. This is the posterior pituitary. Anterior pituitary develops from invagination in oral ectoderm, which is called as the Rathke's pouch, whereas posterior pituitary develops from neuroectoderm. Anterior pituitary secretes hormones from various cells present inside it. Broadly, they are classified into acidophilic cells and basophilic cells. Acidophilic cells are lactotrophs and somatotrophs. Mnemonic is LAS because SLAS. Whereas basophilic cells are corticotrophs, thyrotrophs and gonadotrophs. Mnemonic is BCG is for tuberculosis, B basophils, C corticotroph, G gonadotroph, T thyrotroph. Posterior pituitary as such do not synthesize any hormones. Pituitary gland is under the control of hypothalamus. In the hypothalamus, there are certain neurons called parvocellular neurosecretory neurons. This neuron is connected to anterior pituitary by hypothalamo-hypophyseal tract, and the anterior pituitary is under the control of these parvocellular neurosecretory neurons in the hypothalamus. There are some other neurosecretory cells called magnocellular neurosecretory neurons, which includes supraoptic nuclei as well as paraventricular nuclei. Both of these nuclei synthesize ADH and oxytocin. Major part of the ADH is synthesized from supraoptic nuclei, whereas major part of the oxytocin is synthesized from paraventricular nuclei. After the synthesis, it is transported to the posterior pituitary gland, where it is stored and released from the posterior pituitary gland. A deficiency of growth hormone can lead to dwarfism, whereas excess of growth hormone in child can lead to gigantism, and in adolescents and adult it can lead to acromegaly. Features of acromegaly includes frontal bossing, long nose, macroglossia, prognathism, thyroid enlargement, spade-like hand, increase in the heel pad thickness, and cardiomegaly. This cardiomegaly can lead to left ventricular hypertrophy, diastolic dysfunction, and arrhythmia. Secretion of growth hormone in the human body is affected by exercise, sleep, food, and stress. Normal amount of growth hormone in children is less than 20 nanogram per ml, whereas in women it is less than 10 nanogram per ml, and in men it is less than 5 nanogram per ml. Normally, the growth hormone is released in a pulsatile fashion. So, if we are suspecting a growth hormone deficiency or excess, it is not good to check the growth hormone. So, the best way to check is checking the insulin growth factor 1. Why? Because IGF-1 level also increases with the growth hormone, and the level of the IGF-1 remains stable. So, it is the best screening test for doing in acromegaly. IGF-1 is secreted from the liver. This IGF-1 is binded to a binding protein. There are 6 types of such binding protein in the human body. The most common type is IGF binding protein 3. So in patients with the suspected growth hormone abnormality, if you are checking the IGF-1 and if it is found to be normal, the next best way is to check the IGF binding protein 3. Normally in the human body, growth hormone and the insulin are oppository in action. Insulin suppresses the growth hormone in the body. So 75 mg oral glucose load test is used to detect the growth hormone excess. Normally that level of glucose produces insulin that suppresses the growth hormone to less than 1 nanogram per ml. If it is not, then there will be excess growth hormone present in the body, probably due to an adenoma in the somatotroph. So the gold standard or the confirmatory test for growth hormone excess is 75 mg oral glucose load test. So the growth hormone excess is due to adenoma in the anterior pituitary gland, and the definitive treatment for it is surgical resection. If the adenoma is unresectable, then we can treat it with somatostatin analogs like octreotide and pasireotide, or we can treat it with a growth hormone receptor antagonist like pegvisomnant. Somatostatin is the other name for growth hormone inhibitory hormone. Growth hormone increases, IGF-1 also increases, but there are exceptions like growth hormone increases but the IGF-1 remains normal. Examples are starvation, diabetes and kidney disease. Other name for IGF-1 is somatomedin C.